Welcome back to Microbiology. In this video, we're covering section 16.2, Tracking Infectious Diseases. In the last section, we learned about the language of epidemiology. Now we'll apply those terms to real-world disease tracking and study designs. And by the end of this section, you should be able to, 1, explain the approaches used by the early founders of epidemiology, and 2, explain how descriptive, analytical, and experimental epidemiological studies determine causes of disease. Epidemiology focuses on how diseases spread, where they persist, and how we can prevent them. And modern surveillance relies on 3 pillars: good data collection, recognizing patterns, and testing hypotheses about disease transmission. So this section will introduce the first scientists who use these techniques. John Snow is often called the father of epidemiology. He was a British physician known as the father of epidemiology for determining the source of the 1854 Broad Street cholera epidemic in London. So during the 1854 cholera outbreak in London, he carefully mapped the cases of cholera, and he was able to trace all infections back to a single contaminated water pump found on Broad Street. And removing the pump handle stopped the outbreak almost immediately. This was one of the first data-driven public health interventions and helped support germ theory. This slide compares major types of outbreak spread, and there are 2 major categories: common source versus propagated spread. In common source spread, that means one contaminated source infects many people. And an example could be that single water pump like we saw in John Snow's investigation. Types of common source spread include these 3. In point source spread, the common source exists for a short period of time, less than the incubation period of the pathogen. And an example could be a single contaminated potato salad at a group picnic. In continuous common source spread, this would be ongoing contamination. For instance, the source of that London water taken downstream of the city, which was continuously contaminated with sewage from upstream. With intermittent common source spread, infections occur for a period of time, they stop, and then they begin again. So this is periodically, and we might see something like infections from a well that was contaminated only after rainfall, and that clears itself off after a short period of time until the next period of rain. So that was all common source spread. In propagated spread, this is due to person-to-person transmission. So propagated spread cannot be easily stopped at a single source like point source spread can. And propagated spread usually creates a longer outbreak curve. Examples can be things like measles and influenza. And next, we're going to see how these curves look in real data, how common source looks different from propagated spread. On the left, the outbreak curve shows a point source exposure. It is short and sharp, so everyone is exposed at roughly the same time. In contrast, on the right, propagated spread shows multiple waves because each infected person can infect others. So the difference between these curves and these curves themselves help epidemiologists recognize what kind of outbreak that they're dealing with. The CDC website also has training links you can explore on your own if you're interested. These are interactive modules that kind of simulate real outbreak investigations. So in this exercise that I've screenshotted, they ask us to look at this figure and determine the most likely mode of spread. So if I look closely, the x-axis looks like just a few days. I see single days listed here, and it's short and sharp, so short in duration. That means it's probably an example of point source outbreak, because I can see the curve rises quickly to a peak around August 24th before slowly tapering off. And here's another example from that link. This one asks us for the most likely spread for this curve, and this time I can see the x-axis spans several months, so a pretty long duration. So if I'm coming from October all the way to mid-January or further, that means it's probably, probably continuous common source. So this is a continuous common source outbreak because we're exposed to something continuously over several months. Cases gradually rise from, mid-October to mid-December, and then they start to decrease. So we do not see the multiple waves that we would see in propagated spread, like we saw earlier in the previous figure on that right side. And we do not see point source, which would be like a very sharp and short duration. So because we see this gradual increase and then decrease over a long period of time, it's probably continuous common source. Florence Nightingale's work is another example of an early epidemiological study. In the 1800s, Nightingale was part of a group of nurses that were dispatched by the British military to care for wounded soldiers during the Crimean War. And Florence Nightingale, while she was there, applied data collection methods to military medicine. So she tracked causes of soldier deaths, and she created these pretty amazing detailed diagrams that showed, really surprisingly, that most soldier deaths actually came from preventable infectious diseases and not from battle injuries. And her work eventually led to sanitation reforms in hospitals. So here is Florence Nightingale, and on the right we have her famous wedge chart histogram, and sometimes this is called the rose histogram or rose diagram because it kind of looks like a rose flower, and it has different colored sections. So these wedges, we have each section of a wedge represents a month. I can see that's August, September, and so forth. And the different colors represent different causes of death. So wounds causing death were in pink. Preventable infectious diseases are all the sections in gray, and all other causes of death were in brown. So each wedge represents deaths, the total deaths in a month, and the largest areas are actually from infectious diseases rather than wounds, which is what they originally assumed. And these graphics really persuaded government officials to improve hygiene and ventilation in these hospitals. Joseph Lister was an English surgeon who extended germ theory into surgery. So back then, most physicians did not wash their hands between patient visits or clean or sterilize their surgical tools. Now we think that's pretty gross, but back then that was common practice. But Lister required surgeons to disinfect their instruments and wash their hands using carbolic acid. This is also known as phenol, and this was an early antiseptic technique. After implementing these protocols, the post-surgical infections dropped dramatically, and today modern aseptic technique in hospitals really were built on Lister's work. All right, now that we've completed kind of an overview of our early pioneers of epidemiology, let's look at the types of epidemiological studies. So epidemiological studies fall into two broad categories. We have observational studies, where we collect data without intervening, and we have experimental studies where we manipulate conditions, such as comparing treatment versus a placebo. In observational studies, we're therefore collecting data without intervention, meaning subjects are not manipulated, versus in experimental studies, we are going to manipulate subjects, for instance, by maybe providing some subjects with an antimicrobial drug for the study, whereas the other half of the subjects maybe receive like a placebo pill. Both types of studies help us understand causes of disease, but observational studies cannot directly prove causation. So in observational studies, researchers do not influence exposure. They just gather information through steps like interviews, looking at lab results, or conducting surveys. And these studies can identify associations, but not causation because confounding variables might exist. For example, let's say that a study finds an association between heavy coffee drinking and lower incidence of skin cancer. It's possible that the lower rate of skin cancer is due to not just the drinking coffee, but due to less sun exposure. And this observational study cannot distinguish between these two potential causes. Within the category of observational studies, we have two major types, descriptive and analytical. In descriptive epidemiology, the main question we're asking is what? What is happening? So descriptive epidemiology describes disease patterns. The purpose is to characterize the distribution of health events and generate hypotheses about possible causes. In contrast, in analytical epidemiology, the main question we're asking is why? Why is this happening? So in analytical epidemiology, we're going to be testing hypotheses to identify the cause or risk factors for disease. So let's look more closely at descriptive epidemiology. In descriptive epidemiology, we're looking at trying to answer who, where, and when questions. We track person, place, and time, and this will produce a pattern of disease spread. These patterns will help us generate hypotheses that we later test with analytical studies. So an example of a descriptive study could be, let's say an epidemiologist noticed that most salmonella cases are occurring in a particular city, and all of those cases began within the same 2-week period. They all trace the patients to the same restaurant, and this is a lot of information, but it does not prove the cause of disease. It only really identifies a pattern that we need to investigate further. So we can generate our hypotheses, but we're not testing it yet. It's only in analytical epidemiology that we're going to test the hypotheses about the cause of a disease. So here we're going to compare groups to identify risk factors. Analytical studies can include either retrospective studies that analyze past data of existing cases, or prospective studies that follow subjects forward in time to see who becomes ill later on. So going back to that example from the previous slide on the salmonella cases, let's say that for the analytical end of the study, after noticing a cluster of salmonella cases, the investigators conduct this analytical study where they compare people who ate that, let's say it was a chicken salad at the restaurant, versus those who did not eat the chicken salad, and they find that the risk is 10 times higher. The risk for salmonella poisoning is 10 times higher among the people who ate chicken salad. So lab testing then might confirm that there was salmonella in the chicken salad, and now the cause is established. This table summarizes the differences between descriptive and analytical epidemiology studies. So in descriptive studies, we're looking at what, who, where, and when, and trying to answer those questions, whereas in analytical studies, we're trying to answer why and how questions. Descriptive studies will generate hypotheses, whereas analytical tests will test those hypotheses. Both of them, remember, are still observational studies. For our descriptive studies, this does not prove the cause. It only identifies patterns that need further investigation. Whereas in analytical epidemiology, we are testing hypotheses so we can determine the cause or risk factor. And within those analytical studies, we have the subcategory retrospective studies. These are a type of analytical study within the observational study type where researchers examine past records to identify exposure differences between people who already became sick and people who did not get sick. So the book provides an example where people get sick after a potluck, and it shows a retrospective foodborne outbreak investigation. So the epidemiologists review past health history charts, and they conduct questionnaires to compare potluck attendees who got sick versus those who did not get sick. And they found that 95% of people who got sick ate the potato salad at the potluck, whereas the others did not. So retrospective studies are ideal when an outbreak has already happened. In contrast, in prospective studies, remember these are still analytical and within the observational study category. In prospective studies, participants are disease-free at the start, and researchers are going to track exposures like vaccination status, wearing masks, or maybe even occupation, and track and observe who becomes ill eventually, who becomes sick. So this approach is really useful for evaluating things like new vaccines or new infectious agents. When conducting analytical studies, there are three major types of analytical study designs. Cohort studies, or the cohort method, follows groups forward in time. For example, they could look at smokers versus non-smokers and see who eventually develops heart disease at a faster rate over something like 10 years. In case control studies, we're comparing sick versus healthy groups, and we're going to look back at exposures. So an example could be that potluck example, looking at what these patients were previously exposed to. In cross-sectional studies, we're capturing a one-time snapshot to measure prevalence. An example could be going to a college campus and conducting a survey where we ask students if they currently have the flu or have flu symptoms, and whether they currently live in the dorms on campus or if they live off campus. And this would be to see if there are any associations between where students are living and if they currently have the flu. So each of these designs has its own strengths, really depending on the research question you're trying to answer. So all of the previous slides covered observational studies. And remember, in observational studies, researchers do not influence exposure. They were just simply gathering information from interviews or lab results or surveys. Now we're going to switch to experimental studies. And in experimental studies, researchers do actively intervene. For example, they might give a new medication or vaccine where one group will receive the treatment whereas the other group does not. They receive some kind of placebo. The best way to conduct an experiment like this to reduce bias as much as possible is through a double-blind controlled trial. This means that neither the researcher nor the participant knows which group they're in, and that can kind of reduce bias if neither the patient nor the researcher knows if the patient is receiving the medication or the placebo. And these types of studies, experimental studies, provide the strongest evidence for causation. They can be used to evaluate drug efficacy, evaluate vaccines, or even the best prevention methods for a disease. But experimental studies are not always possible. They're not always feasible. For instance, we can't intentionally expose people to pathogens. So for many infectious diseases, we rely on observational methods instead. So ethics and human safety always guide study design. And going back to that previous clinical focus example we learned about in the first video about the turducken, remember that this case described a salmonella outbreak that was traced to pre-stuffed turduckens from a grocery chain. Do you remember, and what do you think? Is this an example of common source spread or propagated spread? So it turns out that this was common source. So this was a common source outbreak since it was one contaminated production site that infected many customers. It wasn't spread between person to person. And epidemiologists used patient interviews about the food exposure, like what did you eat, to pinpoint that source. Once a source is identified, then the public health officials can recall the products and make sure the contamination source is corrected. All right, this checkpoint asks us to explain the difference between common source spread and propagated spread of disease. In common source spread, all infected individuals are exposed to that same single contaminated source. It could be like water or food. Transmission is not person to person, and these outbreaks usually occur rapidly and end once the source is removed or contained. So one example could be like John Snow and that 1854 Broad Street cholera outbreak that was traced to that single contaminated water pump. In contrast, for propagated spread, infection spreads through direct or indirect person-to-person transmission. So each infected person becomes a source for new infections, and this really results in longer, more sustained outbreaks that are harder to control. So one example could be influenza outbreaks or measles that are transmitted within the community. For the second checkpoint, they ask us to describe how the observations of John Snow, Florence Nightingale, and Joseph Lister led to improvements in public health. So John Snow, he mapped cholera cases in London and linked infections to a contaminated water pump. And by removing that pump handle, that really stopped the outbreak. And this was the first data-driven public health intervention. For Florence Nightingale, she collected data and graphed it, looking at causes of death among soldiers during that Crimean War, and she showed that most deaths were from preventable infectious diseases and not from the wounds. So her findings led to sanitation reforms in hospitals and in military medical systems. Finally, for Joseph Lister, he applied germ theory to surgery. He used carbolic acid, also known as phenol, to disinfect instruments and wounds, and really introduced antiseptic surgical techniques to reduce infection and reduce mortality rates. So this really established the foundation for modern aseptic practice in medicine. So in section 16.2, we really looked at how epidemiology connects patterns in data to figuring out what's causing the disease. And once we know that, we can figure out how to prevent the spread of disease. The pioneers who use data to drive public health reforms really are our founders or first epidemiologists. And modern epidemiology relies on those observational and experimental studies, ethical standards in human research, and looking at how we can apply our findings to preventing disease and controlling the spread of disease. All right, another checkpoint. I'm going to skip this one for now. I have a table for you in the next slide. So let's look here first. Explain the ways that groups of subjects can be selected for analytical studies. So we saw that in analytical epidemiology, we're going to use comparison groups to test hypotheses about disease causes. And there are three main study design types. The first were cohort studies. So in cohort studies, we follow individuals who share some kind of common characteristic or exposure. For example, smokers or non-smokers. And this can be a prospective study where we follow them forward in time, or retrospective where we're using past data. In the second one, case-controlled studies, we're comparing individuals with the disease to those without the disease. Without would be our control group. And for instance, retrospective design could look for differences in past exposures. In cross-sectional studies, we're analyzing information in a snapshot of time, so one point in time of a population, comparing, for instance, diseased versus healthy individuals. And these are used to help us identify associations and determine disease prevalence. So each of these three designs helps us identify risk factors and relationships between behaviors, exposures, and disease outcomes. And this table looks back at that first checkpoint, comparing advantages and disadvantages of observational versus experimental studies. In observational studies, these are often easier to conduct, not as expensive, and sometimes the only ethical option because we cannot manipulate certain subjects or certain cases. But a disadvantage is that these studies can only show associations and not a direct cause of something like a disease. There might be additional confounding factor. For instance, we saw that earlier study that found an association between heavy coffee drinking and lower incidence of skin cancer there could be an association, but we know that drinking a lot of coffee does not lower your risk of skin cancer. There were other confounding factors there. In experimental studies, the advantages are you can control your variables, right? You have your control group taking a placebo, for instance, and your experimental group, and you can come or conclude the cause of something like a treatment or a disease. But these are much more complex, usually more expensive, and sometimes unethical if you're trying to or considering exposing subjects to some kind of risk. You also have to control for bias, and that's why we usually use double-blind study designs. All right, let's recap 16.2. The first one, explain the research approaches used by the pioneers of epidemiology. This was kind of a checkpoint question too, but we had John Snow, that father of epidemiology, who used mapping and data analysis during that 1854 cholera outbreak in London. He traced those cases to a single contaminated water pump, and that was the first use case of mapping and statistical reasoning in disease control. Removing that pump handle ended the outbreak. So that was really the first example of public health intervention based on evidence. For Florence Nightingale, she collected and graphed hospital mortality data and found that most soldier deaths were due to those preventable infectious diseases and not battle injuries. And this data, through those wedge charts, really drove sanitation and healthcare reforms. Joseph Lister applied experimental reasoning from germ theory to his surgical practice. So he introduced those antiseptic methods, and his work reduced post-surgical infections and really established the foundation for aseptic technique and medicine. So all of these pioneers, their research emphasized observation, collecting data, and intervention, forming the basis of modern epidemiology. For the second one, explain how descriptive, analytical, and experimental epidemiological studies go about determining the cause of morbidity and mortality. So in descriptive diseases, we're observing and describing patterns. In analytical studies, we're comparing groups to test hypotheses. And in experimental studies, we are controlling variables to confirm cause and effect. So together, these methods really allow epidemiologists to move from observation to correlation to causation, leading to evidence-based strategies for reducing morbidity, which is illness, and mortality, which is death in populations. And in case it helps, I also created a table looking at the three. Descriptive epidemiology observes and describes patterns. In our analytical studies, we're testing hypotheses using comparison groups. And again, in experimental studies, we're controlling variables to confirm cause and effect. And that takes us to the end of part 2. In the next video, we're going to look at section 16.3, modes of disease transmission, where we explore how pathogens move between hosts.